sponsored by the East Texas Geriatric Education Center and Consortium and our partnership with the Texas AHEC East. My name is Tony Denuzzo. I direct the ETGEC Consortium, and this is something we've been doing for many years, and we're really glad that you're here. And I'm just going to go through a real brief introduction. I do want to let you know that right off the bat, all of our speakers and program planning committee members have no commercial relationships or affiliations to disclose that are relevant to today's presentations. The GEC has been around since 2003, and we target geriatric education and clinical training for health providers and students in health professions. And we have today a series that after our much discussion with our planning committee, we decided to focus on a very important and broad topic of maintaining independence for older adults. Obviously, this is a huge issue. It's a constant type of thing that we try to deal with in terms of what the health providers do, and it covers a large area of study in geriatrics and gerontology. Our session today is going to focus on social isolation, the risks, challenges, in terms of what happens when an older adult has to, for whatever reason, whether it's financial, health conditions, loss of friends and family, find themselves in situations where their life has changed to the point where they are in an isolated situation, and the risks that are involved with that can impact their health. I'd like you to know that this is also available as a webinar, and hopefully we have some people that have chimed in from their PCs if they weren't able to make it today. This is the agenda for today. We'll have 3 presentations and then a break around 2:15. It's real important, by the way, at the end, I'll let you know that we need to have some evaluation of these sessions to get an idea how we're doing and how we can improve for future sessions. These are going to be the 4 topics that we'll be covering for the 4 months of this series. In February, we'll be looking at changes in lifestyle, adapting to maybe not, maybe moving out of a home, moving to a different location, issues with not being able to drive, and other types of things that maybe older adults are used to doing that maybe they won't be able to anymore. That'll be in February. In April, we're looking at the health conditions that may impact loss of independence, such as incontinence, change in mobility, and colostomy. And in May, we have looking at issues related to surgery in older adults and some of the things that may impact independence. This is the purpose. It is in your handouts. I won't read it, but it covers a lot more than this, because it does. We have a great presentation we'll be doing on elder abuse and then looking at guardianship. These are the learning objectives also listed in your handout. We are teleconferencing to 5 different sites, and I switch every now and then so you'll be able to see what they look like. Okay, CE credits. We are offering medicine, continuing medical education credits for MDs, DOs, nursing practitioners, and PAs. In your handout has the way of obtaining CE credits if you apply for them, and that will be an online method of doing it. Okay, we are offering social work CEUs. There's a special sign-in sheet for that, as well as the evaluation form that you will need to fill out for your social work CEUs. And finally, we are looking at CEUs for physical therapy and occupational therapy, for those that want to apply. But if you can come up with a sign-in sheet separate from what you have, that for those that want to request C&E credits, we're going to try to get that done. So just generate a sign-in sheet, and we'll have that set up, and you'll send forms or anything. Apologize for the last minute or the lateness in terms of getting the C&E. We've tried real hard in doing it, and Brian's done a Herculean job in helping us to get that taken care of. So thank you for your patience on that. All right, everyone in this room probably knows Dr. Lee Grumbles. She's presented for us numerous times on multiple topics, and she's always such a dynamic and informative speaker. Her bio is there, and born in Abilene, Texas, which is West Texas, she lets me know. And one of the main things, obviously, is that she's the director of palliative care program and hospice care here at UTMB, and certified in those areas. So the hospice care team, she's provided many talks for us on that. And I want to thank her for taking on this at a last minute. Our speaker had an accident. We couldn't have that taken care of, and so Dr. Grumbles has stepped in to do this presentation.
In the meantime, since it's not going to be extremely interactive for part of it to try to keep you awake, I've gone to the old-fashioned way of having you an outline handout that you're required to follow along through the lecture and take in some notes, okay, to keep everybody awake and alert after eating lunch. So, the topic, addressing social isolation among older patients. Well, when they asked me to do this, I said, yeah, I can find a review article and I'll figure out something. It's on the outer edges of my area of content knowledge and expertise knowledge. But it's not really something that I have a whole lot of experience with. And as I got to thinking more and more, I realized, you know, that's wrong. It's my unawareness of how pervasive it's been in my practice that let me think I really wasn't pretty much a content expert in this. And what I realized is when I thought about all of the diagnoses that as a physician I would put on people's chart, they were many times highly correlated with social isolation. I mean, how many times did I put depression down as a diagnosis in a chart and not address the fact that there was a very small or non-existent social network for that person? How many times have I taken and gone out in the community with a obsessive compulsive disorder patient that's a hoarder and tried to put services and hospice care in that person's home, that I didn't say, well, hospice is having to pick up and be the social network because there is no social network appropriate. How many patients have I put fall as the primary diagnosis? And when I'm talking with the patient, I say, well, who's there? Who checks on you? How do we know? And they're like, there's nobody. So we're having to look at ways to try to support that person. So social isolation is pervasive with many of the common diagnoses that we take care of in the geriatric population. Some other things I got to thinking about were, well, look, it's not just me as a physician who is seeing these patients in clinic. How many times do I write home health orders? And I have the home health nurse go out to the house who actually sees the degree of social isolation, or the PT or the OT that goes out in the home setting and they see the degree of social isolation. You know, how many times do I send patients to the geropsychiatrist or for psychological counseling? So I realize that social isolation is something that we're all seeing. We just need to be able to be aware of it. The other thing I found out about 3 years ago is social isolation is actually a medical diagnosis. There is actually a code that we can use with billable services for social isolation. So in extreme cases now where social isolation is really not just a factor but a major problem with my patients and their comorbidities, I actually use that as a code so there's more attention drawn to the fact that there truly is social isolation that needs to be aggressively treated. Not just addressed, but treated. Okay, the first thing we're going to do is look at the objectives. One of the things you're going to do is you're going to write an objective for social isolation. You're going to write it in your own words. What makes sense to you and what would make sense if you were trying to describe it to someone else. The second objective, we're going to make some lists. We're going to make a list of the negative health consequences that we know are associated with social isolation. We're going to make a list of potential risk factors for social isolation to help cue you on what you need to be looking for. We're going to acquire a copy of the predictors of social isolation. We're going to actually acquire a copy of the Lubin Social Network Scale 6 for you to consider using your screening of your elderly population for social isolation. And we're going to do an interactive activity where we brainstorm a little bit with some pragmatic interventions to try to reduce social isolation. So I want you to take about 30, 60 seconds here, and I want you to write your definition of social isolation. Okay, now that we've taken a little time to word what you feel like your definition is, let's look and see what one of the established definitions is. Nicholson is one of the researchers who does a lot of nursing research in social isolation, and their definition has kind of been accepted across healthcare professions as kind of the standard. And hers is that a state in which the individual lacks a sense of belonging socially, lacks engagement with others, has a minimal number of social contacts, and they are deficient in fulfilling and quality relationships. So one of the things that really comes across in Dr. Nicholson's definition is it's not just a low number of contacts, but something else. When you read in that last few words, they are deficient in fulfilling and quality relationships. So we have to realize social isolation may be that we're surrounded by people, but if they're not fulfilling and quality relationships, we still may be in a state of social isolation. So now, after hearing Dr. Nicholson's definition, take just a second and revise your current definition if need be, to make sure that you're getting the full essence of what social isolation really is. What was the battery? Okay, thank you. Okay, now that everybody's got a good idea of what we're really talking about, and that we're not talking about just quantitative numbers, but we're talking about quality of relationships, let's go on and talk a little bit more about risk factors. So, getting into risk factors, we have to realize that a lot of what we have published is not true risk factors. They're actually documented consequences of social isolation. And there's four major accepted categories for that. Usually there's changes in health behaviors that come from social isolation. There's changes in psychological states that come from social isolation. There's some changes in our condition, our medical condition, with physiological changes. And then there's a kind of a group of others that don't have a real good category. So when we talk about social networks, we say that they can actually improve compliance and they can encourage elders to refrain from negative or risky behaviors. What we've found as a consequence is that when patients and elderly patients are in isolation, they don't take care of their health well. It definitely has had studies that show in populations of patients where there is a good, trusted, quality social support, people are more likely to get their screening colonoscopies done. And there's actually studies that show things like that actually happen. But without those social networks, there's also an increased incidence in negative behaviors, in health behaviors. There's an association with men and heavy drinking. There's an association with smoking. There's an association with sedentary lifestyle. And there is an association in nutritional risk. Okay, I see that all the time. I call them my tea and toast people. You know, social isolation, they don't want to go to the store, they can't go to the store, they have nothing in the refrigerator, so they have tea and toast for 3 meals a day, a bowl of cereal with a little bit of milk, and they become nutritionally at risk because of their social isolation. Some other, when we look at their changes in their physiological state, some negative consequences are there's an increased risk in cognitive decline. The speed of ensuing dementia actually occurs faster in patients with low social networks. There's also in elderly men a direct correlation with the incidence of death from suicide, not in women, but in men. So from a psychological state, we definitely can see that. Conversely, we have to understand that older adults who have a very extensive social network are protected from dementia. So I'm not just trying to present here the negative outcomes, it's actually we're seeing there's something positive. You know, not just do we keep it status quo, we can actually improve someone's condition by enhancing their social networking. Changes in physiology, there's some very good research that talks about correlations with increased incidence of coronary artery disease, increased incidence of stroke, and I thought this was kind of interesting. There's actually, it's an increased predictor of acquiring the common colds, which intuitively I would have thought it would have been just the opposite. You know, the less exposure you have to the community, the less likely you are of being able to acquire a virus. But in actuality, the study is saying that you have an increased incidence of colds in the social isolated population. These other changes are things that we all intuitively kind of know about. You know, all-cause mortality, increase in falls, increase in rehospitalizations. We see that all the time in our inpatient hospital settings. We get someone stable, we get them tweaked up in the hospital, and we send them home in their home environment, and there's not a stable network, social network at home to support them being able to maintain at home, and they wound up coming back and being readmitted in short time back to the hospital. Also very well established in the research literature is that social isolation is a major predictor for institutionalization into the nursing home setting, in our long-term care setting. Now, let's go over some categories of potential risk factors for social isolation. And I want to stress the word potential here, because I had kind of always known all these, quote, risk factors, but I had a feeling they were all kind of proven in research. It was kind of a no-brainer to me. This is something that could easily be looked at, easily be documented. But in actuality, what we find is the negative health consequences are very well documented in our research literature. Risk factors, on the other hand, aren't so well documented. And many of them really are implied to be a risk factor, but we really don't have the research to definitely say they are. And the five basic categories that we look at is there's some physical risk factors, some psychological, some economic, some just overall changes in one's lifestyle, and environmental risk factors. So we'll look at each one of these separately. When we look at the physical risk factors, one of the things that we have is poor body image, especially associated with being overweight. There is research that does show as elderly people age, and if they are overweight, they are going to be more likely to become socially isolated. We're unsure of whether that is due to the problems with functionality or whether that is more of a psychological problem with the true body image. Another is there's some good research that shows with a high number of health problems, and the research cutoff is kind of 4. If you have 4 or more chronic conditions, you're much more likely to be socially isolated. People with less than 4 chronic health conditions, they have very significant reduction in the incidence of social isolation. Sensory loss, people with decreased vision, people with decreased hearing, all of those sensory problems, intuitively it makes sense to us that those people would have an increase in social isolation. And actually, there are some very good studies that have actually shown through the National Council of Aging that the sensory system is one of the big things that we could say is truly a risk factor. It has been correlated and proven as a risk factor for isolation. Urinary incontinence, out there in the research that's showing that patients with large volume urinary incontinence, it's about 5.6 times more likely if you have high volume urinary incontinence, you're going to suffer some social isolation. You know, the just our cultural embarrassment if we go out in public and we have an accident. You know, I know I've had many elderly women that just tell me, I'm not going to change from a pad to a Depends. You know, it's just, for me, if I have to wear that and go out in public, I feel like people will know because of the extra, you know, padding and volume around my hips. So many times that keeps people in their homes. Sleep disturbance. Some people with sleep disorders just don't feel well enough in the daytime hours to be active and be able to engage with other people and go out and be active. And then functional disability. Once again, it's intuitively for us to understand that people who are functionally disabled would be less likely to be out of their homes, and if they're less likely to be out of their homes, they're less likely to have a larger social networking. For psychological factors, this was the no-brainer, I thought, for me. I've always assumed if you were depressed, there was a high likelihood that you had social isolation and that it was directly a risk factor. Well, there's a lot of people that believe that, but there's really no research to actually support it. A definition, or actually a statement that was made by Blazer in 2005, who does a lot of research in this area, he said it's a clear but not obvious relationship between depression and social isolation. For the social workers in the room, just to let you know, there's been a very good qualitative study that was done with the social work industry, fairly large study across the United States. And what they found was the social workers who were dealing with these people with social isolation in the community setting said that in their minds, there definitely was a correlation between depression and between social isolation. So whether we have the research to actually confirm that or not, we definitely have the subjective impression in our healthcare professions that there is a tight correlation with the two. Poor quality of life, there's very little research in that area, and of course with my interest being palliative medicine and hospice, and I deal with quality of life, what we're seeing is that there's new emerging research that's looking more and more into this area, primarily looking into the area of elder with cancer diagnoses. There's some research that shows if you were in social isolation before you were diagnosed with a cancer, your outcomes are more negative and poorer outcomes than if you are case controlled with someone that has a better social outcome at a similar diagnosis, staging, and treatment level. So we don't understand really what's going on with quality of life, and it's an area that just in the last couple of years has really started moving forward in palliative medicine and supportive oncology care and in the oncology circles. A lack of religious engagement. As we've heard from other lectures in the past that we've had here at GEC, when we look at religious engagement, we know that there is some research that supports that if someone has a prior religious belief structure before becoming sick, their outcomes are usually more positive than people that don't have them. And in fact, I found this interesting in that there's a specific study that's looking at the religious background that preceded, comparing it to mortality among the older adults. And what was found is there is a 2.3 times more likely to die if the person had no pre-existing religious engagement. And when I say engagement, I'm not meaning a belief system, I'm meaning an activity where they go to a church or meet with a group for religious activities. And I thought that was a fairly significant statistic to think about. Cognitive decline, of course, is something that we're very, very interested in our geriatric population. And the research does show that with a decreased social network and with social isolation, there is an acceleration with cognitive decline. But there's also that reverse that I was talking about earlier, a protective. If we can enhance, not just eliminate social isolation, but if we can have enhanced social networking, we can actually provide a protective mechanism for cognitive decline. Now for economic risk factors, what they actually mentioned in this article is when they were talking about early retirement. And this was another one that I wasn't aware of. It talked about, it seems to center around elderly women. And when elderly women retire, they seem to have a negative health consequence from early retirement. And it seems to be a risk factor for having low social networking. So it seems like if you're someone who has a large social network, you're less likely to retire early. Now to me that seemed kind of counterintuitive. I'm a very gregarious, outgoing type person, and so I like all the people I work with, and they're part of my social network. And so I would think that it would keep me working longer if I had a large social network and considered the people in my working environment part of my social network. But in this study, it actually shows that women, even if they have a low social network, that they have negative consequences. It's as if they're losing the people at work, and that network is decreasing and they're having a negative impact from it. But I don't believe that they realized that the people at work were part of their social network. They didn't validate or realize that. So that was a very, very interesting study. You don't have to worry about me. I can't retire until I'm 90 because I didn't go to medical school until I'm 36, so I got school loans to pay until about, I think, 96. I calculated out. I would finally have my school loans paid off, so there will be no early retirement out of me at all. Now another risk factor is changes in our family roles. And this makes sense. You know, we lose children, we lose spouses, we lose jobs, anything that really makes a major change in the continuum of our life during our elder years is going to significantly impact our social isolation. Now for the environmental risk factors, these are things that luckily, many of these we can actually make changes in. You know, safety issues. People are socially isolated because they feel unsafe leaving their house and their communities for whatever reason. Living alone. Living in, you know, a house or an apartment where there's no one else around with them. Potential risk factors, advancing age. Of course, we can't do anything to correct that, but we definitely know that is a risk factor. There is some research when we look at ethnicity and race. What we see is that there's a variation in the risk of social isolation when we look at ethnicities and races. What we find is some races are more likely to provide good quality social networks. An example is the African American. They are more likely to have a smaller social network in many cases. But it's a very strong, close-knit, positive social network. So when you compare elder African Americans with elder Caucasians, we see a difference in their risk of social isolations that appears to be purely based upon their ethnicity and the culture that's associated with their ethnicity. Another study that I found very, very interesting was from China. And a couple of nurse researchers from America went back and were studying in China the fact that in China, elderly people without a good social network usually do pretty darn good well, taking care of themselves. It's as if because they're on their own, they learn to compensate, they learn to problem solve, they learn to accept responsibility for what's coming out in the outcomes in their future. Where when these nurses said, well, when we came to the U.S. and we studied and learned and started researching in here in the U.S., we see the opposite. We many times don't see elders engaging actively in trying to prevent problems from social isolation. And so these two ladies are doing a lot, with actually a lady and a gentleman, are doing a lot of research trying to see what is different within the Chinese culture and the Western American culture that's causing this very vast difference in presentation. Of course, risk factors are sometimes changes in salary. When we do retire, many of people are going to have significant changes in the amount of money that they have to provide themselves what they've considered in the past social activity outlets. Changes in the socioeconomic status correlates with the changes in salary. Once again, there's some education level of education. People with less than 12 years of education are found to be more significantly prone to having low social networks and having social isolation. And then, of course, loss of intimate partners makes total sense. How many times do we see a very active husband and wife couple, happy, doing things, going to church, going out with friends, doing everything, and one of them loses their spouse and their life partner, and all of a sudden that remaining partner shells theirself in with no socialization, no networks, kind of putting a wall up around us. We see and deal that all the time, and we see it early in the grief process, and it's okay. In the early part of grief process, a little bit of me time for self-reflection is considered normal. But when it extends out, it then becomes a risk factor for this prolonged social isolation. Now, the variables that actually predict social isolation that we actually know, there's only about 7 studies that are actually out there that show us something statistically that makes a difference with that. And I've made sure that you've got the article, review article, that has those. But they're pretty much the things I've been talking about, but you can actually look and see what things are definite researchable risk factors and what are things that we in the health professions that we've just kind of, we've implied that this was a risk factor because we keep seeing it consistently. Now, let's talk about how do we know when somebody's got social isolation. We've got all these risk factors that you're going to keep in your back of your mind to think possibly this person does. Well, do we have some type of screening tool that would help us to actually designate someone as being high risk for this social isolation? And there's actually a validated study by Lubin. It's called the Lubin Social Network Scale. And there's actually 3 different variations of the scale. One of them is just a revised regular 12 questionnaire. It covers 3 different domains. And then there's a more bigger one that has 18 questions that's used primarily as a research tool. And then there's a screener that just has 6 easy to answer questions looking at the 3 domains. And I've made sure that you have a copy of that so that you could look at that and consider whether that is something that you might want to consider implementing in your healthcare practice. It could be something that a home health nurse could actually take into the home and screen in a matter of 2 minutes with questions. It's something that the nurses on a geriatric ACE unit or a geri clinic could easily screen for. It's something that the social workers, that the physicians could easily apply because it's very, very short. It is validated, and it is validated with a for you researchers out there, it's validated with a Cronbach alpha coefficient of like 0.78, which is like as good as you get. It's like 0.6 to 0.8 is considered where you want to be with validating a type of scale, screening scale like this. And this Cronbach alpha is like 0.78. So this is a well-validated tool that you could integrate into your practice at many different levels in the healthcare process to screen for this. Now, what I want to do is, you don't ever get out of one of my lectures without having some type of interaction. So I want everybody to engage, kind of break up into small groups of 5 to 8 people, and I want you to do a little brainstorming. Okay, I want you to think of 5 different interventions that you could implement in a community dwelling setting to try to reduce social isolation. So what you may need to do is stop and think about people that you've taken care of in the past that had social isolations, and what were some things that you could recommend to try to improve their social networking and reduce social isolation. So we're going to take 5 minutes. So I'm going to have everybody kind of break up, do that. I'm going to call everybody back in 5 minutes, and we're going to open and unmute the other sites, and we're going to talk about and call out and talk about some of our brainstorm activities. Can somebody from Lamar give me an example of what they came up with as a possible intervention to try to address social isolation?
I have 4 that I listed. One would be a calling tree, congregate meal, church, like a parish church, visiting or church meetings, making sure people travel there, and some type of community activities such as plays and music that they get transported to.
And then I have maybe volunteering, finding something that they might like to do and go out and volunteer. And then also finding something that they love to do and also a group of people that love to do the same thing and do it together.
Okay. Very, very. Okay. Very good.
Okay. We talked about mobile church, where the church could come there and have community services at the dwelling where they live, or take them out. We talked about cooking classes, specializing in, old-timer home-cooked food. Computer classes for the elderly or the disabled, so they can expand their social network even electronically. Community gardening that could take place in a dwelling, where they can actually help with the upkeep of the grounds. And involving them maybe in the Boys and Girls Club, where they interact with younger people as volunteers and mentors.
That was some very excellent ideas, because you not only found ways to get social isolation down by networking, but you also found ways to address some of those risk factors, because I can see the cooking classes being good old time cooking. We could be, well, how do you only cook for 1 or 2, or how do you cook things that you could make multiple meals out of? So you could actually address some of the risk factors and some of the activities you came up with. Very, very good. Very innovative. Weatherford College. Let's get Weatherford College to unmute and tell us if they have something to add to our list.
The list that I've heard so far is pretty comprehensive. The only problems that I see is a lot of your communities that are the more rural and smaller communities don't have access to a lot of these great ideas. I love the ideas, but the problem to address is these shut-ins that live, where they don't have access to the services available. We were just talking about a lot of the local churches will provide people to come into the homes and spend time with them, and so the problem becomes the people that are not that don't have these services available to them. You have to be a little bit more
creative and innovative, because yes, someone had to develop ways to put these activities into the more urban setting. They weren't all here 15 years ago. Adult daycare is a phenomenon that's only been out for 15 years. And yes, there's not an urban area that doesn't have an adult daycare hardly anymore. So what we need now is to expand into our more rural communities, looking for ways, how can we modify these existing programs? An example I could give, I love the cooking class idea. I love the cooking class. There's not a church in a rural area that doesn't have a fellowship hall with a kitchen in it. Networking, getting elderly people to the community, the rural community church, and then having them to have the cooking classes together. I can see ways that you could become very innovative to try to make some of these activities work, even in the rural area. That was a great exercise. Y'all did very, very good with that. But now I want to take it a step further. I'm very interested in community dwelling. I do a lot of home hospice care. I'm totally, sensitive and aware of the home, community social isolation, but I have a special love for nursing home patients, especially the end-stage dementia patients. Many times people will say, well, mom's at home by herself, and we have to put her in a nursing home, and they think I'm going to put her in the nursing home and social isolation is going to go away. That's not always the case. Many times elders don't feel comfortable with the activities that they have at the nursing home. And an example I'm going to give you is, years ago I had 5 young gentlemen less than the age of 60 down to the age of 32 that had severe functional debilities, and they had to live in a nursing home. Well, they very quickly informed me that going and playing bingo and weaving baskets and watching the chick flicks on TV was not an activity that they were interested in doing. So they had a lot of social isolation. They're just like, hey, I'll just stay in my room and watch TV. You're not doing anything out there that I'm interested in. So my concern for this population, since I had several of them, I talked with a psychologist who worked at the facility, and I said, what can we do? So he started Friday night with the boys. And we had a special place in the back of the nursing home that the boys went. I wrote orders. They could all have up to 2 beers apiece. And they would go watch an action movie or a sports game or talk about something. And they loved it because they said, we're finally, once a week, we're doing something that are boy things. He said, all you do at the nursing home is think about girl things. You don't ever think about boy things. So we can actually perpetuate social activity from a gender bias within the nursing homes. Something new that has happened the last 2 years in long-term care is the state of Texas has now decided that elderly people in jerry chairs who cannot remain awake and interactive should not sit at a nurse's station because there's no dignity if you do it. Well, I can tell you that really makes the hair on the back of my neck stand up in anger, because the fact of the matter is I write specific orders. All the fellows will here can attest. I say, stop that peg tube for 4 hours, and 4 hours a day I want them in a jerry chair, and I want them out somewhere where there's some activity and noise and commotion going on around them. I don't care whether they can speak and interact. I want them in the middle of that controlled chaos for 4 hours a day, because that's their level of social isolation. Now, I know I'm going to butt heads with the state over this now with this new rule that they've came up. But once again, that's an example of social isolation in the elder. If you say, oh, they can't stay in the room because they can't interact, so they just got to be off and away from where all the other activity is. So what I would like us to do now is to take the 5 more minutes, and I would like us to talk a little bit about that. See if you can come up with some other ideas than what I had, a couple that I've come up with, on how to enhance social networking and decrease social isolation in the long-term care setting. So let's everybody, it's 5 minutes to 12 now. Let's take 5 minutes. I'm going to bring everybody back at 1, and we're just going to spend a couple of minutes talking about some of the things that we've come up with. We let the external teleconferencing sites talk about the community dwelling. Now I want to give UTMB a chance. Let's get the UTMB side here. Let's hear from y'all. What did y'all come up with, some activities or some interventions or engagements that you thought might help in the long-term care setting to decrease social isolation? Pet therapy, great.
Pen pals between different nursing homes.
Pen pals between nursing homes, I like that. Very innovative, good.
Maybe something from a policy perspective, having the local schools, public schools, kids from them go and perform either Christmas musicals or choir performances in the nursing home, and giving some incentives for schools that do that.
So working out in the community to increase the relationships, the active relationships between our churches and our schools with activities. And I can tell you the nursing homes love that. Boy, combine children with pet therapy and we've got it made, you know. It's going to make a big impact. What else can we come up with?
Touch therapy.
Touch therapy, good, very good.
Plants.
Plants, gardening and plants, just like we could do in the community activity, we can do that in the long-term care activity. We actually do that at Gulf Healthcare. A group of medical students sponsored building a bedding garden area that was built so the wheelchairs could roll up underneath it and had a concrete slab underneath it, so we could actually do gardening activities with our elders, and it was wonderful. They loved it. That's a very good idea. Yes, ma'am.
I kind of like the idea of volunteers coming and maybe having like a girls' day out where you go get manicures and that sort of thing, or a guys' day out, whatever guys do.
The contrary to the guys' day out, a girls' day out.
I don't know what that is.
Very good, very good. I know lots of nursing homes that do have, red hat parties, manicure days, things like that, where they do try to cater to those more female type luxuries that we were used to when we were younger and kind of probably miss a lot as we move into the long-term care. Well, that's very, very good. I think we've gotten some good brainstorming activities on what we can do in the community to reduce social isolation and what we can do in the long-term care setting now. Now what I would like to do is just kind of open it up to questions or any comments that we'd like to share with we have maybe 5 minutes before we have to move over to the next lecture. So does anyone have anything they would like to share?
This is SFA, and our groups have just been working tirelessly. They've got some really good points, so we wanted to share their thoughts with you.
Okay.
One of our group members, one of our group members talked about as far as like getting together and having people come out to a long-term care facility and talk about. She was actually saying where she had worked, they like shelled purple whole peas together. And just doing something together they've done in the past, working on a farm or garden, or how to make butter rolls, like having somebody go out and, teach them how to make something that, we don't really make these days sometimes. Or if you're having a Christmas party, someone said that you can have those who are isolated that don't have family members come out and adopt a grandmother or grandfather and meeting their needs because they don't have family. So going to see what they need and maybe for a Christmas party, having someone come out with a gift or those things that they did need.
Good. Some very, very good ideas to add to our list of things. Stephen F. Austin, thank you for the participation. I'm going to go ahead and open it up now for questions so I can kind of get things closing down for the next lecture. Do we have anything anyone would like to share or questions they'd like to ask? Let's see, Richie, I think you had something?
Yeah, it's not a question, but one of the things that I found, I actually run a volunteer program and all my volunteers are 55 and older. And one of the interesting things that I found is that for my volunteers who typically are staying at home and are somewhat physically isolated, I usually get them to participate in something called telephone reassurance. Well, they call another person and check on them, and what I'm seeing happening is that they no longer see themselves as the person that's isolated. Their perspective changes, and it's remarkable the difference that it creates. It's really neat. And then one other comment, I said I run a senior volunteer program. This program is all throughout the United States in different cities throughout. And I would encourage each of you, our volunteers like to go and do sort of this kind of thing, especially with people that are living at home and are somewhat considered isolated. Y'all should take advantage of it. Contact them. It's if you go to TexasSeniorCorps.org, it's TXSENIOR. I can send it to Lee or to
Send
Tony.
a link to Tony.
Okay, I'll send it to Tony. But you can find people in your area for you guys that are in other places in Texas. It's a wonderful thing to do, and it makes a huge difference. And you would be amazed how much the isolation situation changes, and at the very least, the mindset. Where they don't. It's kind of like Lee was telling me something earlier about how, at one point, a section of people they were dealing with had really nice clothes to wear for a certain thing they were doing, and suddenly their perspective changed, and they felt special, and I see that happen with my volunteers regularly. Their perspective changes. Suddenly, they're the person doing for somebody else, and somebody is in need, and it's not them. I mean, it's amazing.
Thank you for sharing that. I'm going to take now and let Tony kind of close. Tony found a very good case study that we can do on our own, or if you wanted to do it as a group after the fact. I'm going to let Tony kind of carry that in and let him kind of close his presentation out.
Yeah, I thought that this case study about Dorothy, the 77-year-old, who was very active in the community, suffered a fall, and more or less went downhill from that rather quickly, it seemed. And I thought it just brought out a lot of the common risk factors and maybe a syndrome where things kind of followed one after the other in a very declined social and emotional and as well as physical and mental way. And I was trying to look at this and see something that really stood out with all these types of situations that happened after she sustained her fall. And the thing that really got me is when they took away her driver's license. And you know, the loss of transportation, the ability to get around, get out of the house and move to wherever she wanted to go bowling, whatever. And was that going to be enough? And you know, so you lose your driver's license doesn't mean you still can't drive. So you know, I know some are just, well, I'm driving anyway. Well, then they tow the car away. All right. So what got me thinking was that many, especially we brought out the church services, church activities. Many churches have van services. So I was thinking in terms of providing more transportation, you know, how active and how really out there are they finding out those that can't make it. This person, Dorothy, more or less had a neighbor who came over and saw that she was going downhill. It doesn't bring out anything, but it does show after just a few weeks that she, you know, I saw her through the window and she was just there crying and just having such a hard time. So it has a lot of good discussion questions to just think about. And as far as all the different roles in medicine, nursing, social work, as well as other therapies and other potential interventions that might make a difference. And so, you know, maybe, especially in rural communities, you know, getting access to transportation, I think, would be crucial. Just my thoughts on that. If anybody has anything else to say or comment, we have a minute, we can do that.
You know, as you were pointing out, just following up on your point that being help to someone else takes your worries away. I think that's a beautiful concept, and it's very true. If you can offer some assistance, and so kids who don't have parents or teenagers who feel not opening up to their parents, if you just need to go talk to someone and have a listen without any judgments or opinions, and that is a good way to, it helps both parties. One is listening and the other feels they're being, maybe in turn they'll give us some advice back, which may be taken much better than advice given by your friends or your parents.
I was thinking that was a really good point, because many times, you know, the children have to adjust to parents who have always been very maybe active and they've seen them do things, and it's very hard for the children to see this change in socialization or with change of health, and so then what to do about it as well. It's an awareness issue. All right, well, thank you.